The first questions, there were a couple of those regarding the number of studies included in the meta-analysis. So is there a minimum of studies that we should put to get a reliable estimate? Or can a meta-analysis include 2 studies only? And what's the maximum number of studies which can be included in a meta-analysis?
Yes, we do meta-analyses of 2 studies. You have to be a little bit cautious with 2 only, because particularly if they're very different from one another, because what if you've got 2 studies which are wildly different, what can you really judge by an average of those 2? There are other problems with 2 studies about uncertainty. It is fine, but it's more difficult with 2. Once you get to 3 or more, inverse variance and standard methods are generally okay. There is no maximum. You do get meta-analyses of hundreds. I've certainly seen meta-analyses of over 100 studies. It's very tedious and time consuming to do. And obviously you can't really have a forest plot because you just simply can't see it. But there is no maximum. I don't know what the largest ever has been, but certainly there are, in Cochrane at least, there's at least some with hundreds. I don't know what the largest ever is done though. Yeah.
Okay, so another question. If my systematic review has 20 studies and each study has 4 patient-reported outcome measure questionnaires, for example, but 2 of those questionnaires were same in all studies and the rest 2 may vary, can I do a meta-analysis here?
Yeah, this is all patient-reported outcome scales are always difficult because, of course, we need to think carefully about how comparable are they, and this comes back to this issue of are they comparable? If you've got the same measure across multiple studies, then that's normally absolutely fine. Yes, you can meta-analyze normally using a mean difference. If they're different but they're estimating similar things, so for example, they're all pain scores, we often use a standardized mean difference there. So we do pull different measure scales, but we'll use a standardized mean difference to account for the fact that there are different scales. There was a session, there is a training session available on evidence effects. So yeah, but it's a difficult, because it will very context depends, and you'll have to think carefully about exactly how comparable are these scales. Are they measuring the same thing in some sense or not? And yeah, that's a difficult one because it will be very dependent on the exact topic.
Hey, how to assess bias of a given publication which did not provide enough information for? Is there any attempt in harmonizing protocols for having more transparency?
I'm not a specialist in bias assessment, I'm afraid. So I don't know the answer to that one. Again, I'm a statistician, not an expert in bias assessment. We don't normally deal much about risk of bias in meta-analysis itself. We probably should do more. We tend to sort of ignore it a little bit unless trials are really clearly terrible, really high risk of bias, and we want to exclude them. That's generally the only reason we would think about them in meta-analysis.
In a study of chronic respiratory disease, the outcome of interest is self-management ability and improvement in health-related quality of life. Can data from studies on asthma and COPD be analyzed through a meta-analysis?
I don't know if there are many questions like this, but obviously I can't tell you about specific areas. I don't know enough about asthma or COPD. Again, you have to, yeah, you'd have to discuss with clinicians about is comparing COPD and asthma, are they sufficiently similar? I just don't know. That's a clinical area I can't comment on. Again, this is why we need, clinical representatives in systematic reviews. You need people who know the data, know the field to tell you, no, those are just too different. Those are totally different disease conditions. We can't possibly pull them. Sometimes the clinicians are wrong, but yeah, you have to be. But again, I don't know if there are more questions. I can't answer questions on specific review issues or specific medical topics. I'm afraid I am a statistician, not a clinician.
Okay, so what are the things to be mindful about conducting meta-analysis for economic evaluation studies? One school of thought clearly states that since settings of countries and participants' characteristics are so different between and within the countries, that through the outcome measure, that though the outcome measure are the same, they should not be combined into a meta-analysis.
Again, Meta-analysis of economic evaluation is quite a new field. Not many people have done much on it. Again, I'm not a specialist in that. I think it's still quite a new area. I don't think there's a convincing answer in here. I think you have to be cautious. I agree that, yeah, different countries have very different settings, and you'll have to judge, are they similar enough to combine? But again, that's something that a specialist economist would have to consider. It's not something there's not a statistical issue. And it is a fairly new field, so I don't think anyone will have a precise answer to that one.
Next question. I see clinical studies using crude odds ratios, adjusted odds ratios, and raw data from eligible studies when conducting a meta-analysis. What will you advise regarding the choice of data to be used among the three options?
Always a tricky one in meta-analysis because we do see studies reporting different things. Adjusted would normally be preferable, but you get the difficulty that people have adjusted for different things. Will have adjusted for different parameters, so they may not be quite comparable. Sometimes you just have to pull what's there. We'll have to accept that we're mixing some adjusted and crude odds ratios. It depends how consistently the studies have reported them. It's a difficult area without individual level data to actually analyze the data yourself. It's almost impossible to be perfect on that. Again, you'll just have to make a judgment on, is adjustment really critical in this field that I wouldn't trust the crude odds ratio, or things like that, or what is the critical adjustment factors? Again, a lot of these questions are things that they're not statistical issues, they're things you just have to think about with in the practicalities or with a clinician. I got these things. Do you go to the next one?
Can risk ratios, odds ratios, and hazard ratios from high quality studies, identical in all other aspects, be combined in a single meta-analysis if the only difference is the type of effect estimate reported?
With great caution, yes. I would normally advise against it if at all possible. Ideally, we'd be looking now. As we've seen in the example, we'd prefer to use the actual raw numbers of events where possible in studies. Admittedly, that isn't always available. We can combine risk ratios, odds ratios, and hazard ratios together. It normally has to be a fairly rare event. As soon as events become more common, odds ratios and risk ratios are not the same thing. So if they're fairly rare, then that is safe. But with considerable caution, I would normally do a sensitivity analysis separating them out just to check whether they're different results in case they are giving different out. So you're just a meta-analysis, the risk ratio studies, a meta-analysis, the odds ratio studies, and a meta-analysis, the hazard ratio studies separately to see if they're actually different. But it is doable if you really have no other choice. Yeah.
Okay, so is there a standard for an acceptable heterogeneity? They're referring to the I-square. They're asking maybe for the I-square.
I think that's better covered if you attend the heterogeneity session. We can discuss it even well. There is not. This is a big topic area. I really didn't have time to talk about it. No, I think is a simple, very quick answer to that question. It's a sliding scale. Heterogeneity is a scale from essentially 0 to 100%. There is no acceptable heterogeneity. There's no such thing as acceptable. It will depend on your context. We talk about as a very loose sort of thing that 25% or less is small, 25 to 50 is a bit, and over 50 is quite a lot, and over 80 is really quite a lot. But there's no sliding scale. I will answer the previous question. There's the ones about publication bias, not risk of bias. So if you don't, I don't know, I forgot to go back to the previous question.
Yeah. There's another question. How do confidence intervals and prediction intervals differ in meta-analysis, and which one is better?
Oh, yeah. A confidence interval tells you about where you think the truth lies in the meta-analysis. So where the true risk of a headache would be in our headache example, for example. That's what a confidence interval tells you. A prediction interval tells you what might be the result of a new study. If we did another study on headache using caffeinated coffee or decaf coffee, what would its result be? And that's a slightly different question. And that depends, again, are the studies similar to each other? Are they heterogeneous? I see Darius just put in the chat. I very much encourage everyone to attend the session on heterogeneity, which is going to come up shortly. and a lot of these questions will be discussed there. So yeah, so with normally it's a constant interval, we're talking about the effect and what the effect estimate is. Prediction intervals are more about what might a future trial say. Yeah.
Okay, so yes, there's another question about publication bias. So many people write that they did not perform publication bias assessment because less than 10 studies were included in the meta-analysis. So do you think this statement is correct? What can our next steps be in the meta-analysis after the inspection of a funnel plot if we notice an outlier, so to say?
I could sneakily say, if you want to know more about this, read my paper in Systematic Reviews from about 10 years ago on funnel plots and publication bias. Um, yeah, we don't recommend funnel plots or publication bias assessment with less than 10 studies because it's very clear that they can't detect publication. If you have fewer than 10 studies, you simply can't detect publication bias anyway, and any conclusion you make will simply be wrong. So yeah, we don't normally recommend it when they're less than 10. If you do notice, if you obviously got an outlier in your meta-analysis, it doesn't just depend on the funnel plot, but you have to think about why that might be an outlier. What are the reasons for it? Is it something to do with the study? Should it be in the meta-analysis at all? Again, the heterogeneity session will cover a bit more on this.